So thank you everybody that is joining us today. My name is Katie Adams. I am the program manager in the Sparkman Center for Global Health. And we're really excited for this session today to hear from Dr. Soliman. He is a professor of community health at the City University of New York School of Medicine. And he's also director of the Cancer Epidemiology Education in Special Populations Program, which is a research training program funded by an NIH NCI grant since 2006 that focuses on research training of graduate public health students in the fields of cancer epidemiology and cancer prevention in international and US minority settings. If you have questions, you can drop those in the chat during the presentation, or you can wait until after to ask your question. And now I think Dr. Waterboer will say a few words and we'll get started.
Thank you, Katie, and thank you, Amr, for being a seminar guest today. Dr. Soliman is one of my favorites in the field of cancer education, cancer prevention, cancer control. He and I go way back, I guess 18 or 20 years, although we still look just as young as we did then. And Amr at one time almost came to UAB. I actually hope this is not the purpose of this presentation. He joins our faculty at some point because he would be a big plus. He runs, again, a cancer education and training program, and I think like no other, and he's very talented, and he's a very great researcher and knows global health, which I do not. You know, I have the CARES program, which is somewhat similar, but that's totally in the US. So we're happy for Amr to try to recruit students and otherwise publicize his program that I think some UAB students may want to take advantage of. Again, he's an expert in global health, and I would highly recommend working with Dr. Soliman or under his tutelage for any students who want to do that and have this interest, because he certainly is a fine gentleman and can be trusted and knows what he's doing. And again, multi-talented and very capable. So I'll turn it over. I'm getting tired of giving compliments, so I'll turn it over to Dr. Soliman.
Thank you very much, Dr. Waterboer, and thank you, Dr. Shrestha, for the invitation, and thank you, Katie, for the arrangements. I'm very happy to be here today to talk to you about the CEESP program, or the Cancer Epidemiology Education in Special Populations program. And as Dr. Waterboer mentioned, I've been running this program for 16 years, and Dr. Waterboer used to come and advise us in the beginning when we started this program. He started maybe 5 years before us with his R25 program. But this program started at the University of Michigan School of Public Health, and has been moving around now for some time, and now it's in New York. So I'll start my presentation by giving you a quick overview about cancer globally and the future projections for cancer and why cancer is important. Then I'm going to move to the resources that we use for cancer research. So I'll give you some overview about population-based registry and hospital-based registries. Then I'm going to give you a quick examples of the research studies that we do in Africa. We have a study in North Africa and a study in Sub-Saharan Africa, and we place students in these ongoing research studies. Then I'm going to talk about the translation of epidemiology to cancer prevention and control, and how we use the data that we collect from epidemiologic studies to think about tailored interventions for populations and countries based on our research findings. I'm going to end my talk with talking about the CEESP program and the mentorship and career development that we provide through this program. And I'm going to give you some time to ask questions in the end of this presentation. So as you know, in epidemiology, we start from descriptive epidemiology, questionnaires, very basic studies to get information about incidence, mortality, survival, unusual presentation of cancer in different populations. And the information that we collect from the descriptive epidemiology study, we take to plan our etiologic and epidemiologic research on cancer to understand why people get cancer, gene-environment interactions, and think more about risk assessment of populations based on the data that we generate from our epidemiologic studies. Final outcome from this cancer epidemiology paradigm is to move to cancer prevention and control. So from the descriptive studies and the etiologic research, we translate the findings into early detection screening, but we also think about tailored therapy and palliative care based on the information from epidemiologic research. I used to show this figure a long time ago, and it only included etiology when I started showing this. But now we use epidemiologic data to talk about treatment, to talk about prevention, not just etiologic findings. So this is like getting the pieces of the puzzle together from descriptive epidemiology and questionnaires, doing some molecular epidemiology research and understanding exposures when questionnaires are not very effective, especially if we ask people about their past exposure. We also have molecular and genetic epidemiologic studies to understand the differences in susceptibility and the impact of environmental and genetic factors on tumors. So all these pieces of the puzzle, when we get together, they help us to understand the etiology of cancer. But more recently, we get the pieces of the puzzle to think about tailored prevention strategies and also to think about treatment and how we can think about treatment of the same cancer in different populations in different ways, because the distribution of cancer and the etiology of cancer will definitely reflect on how we think about treatment of cancer. I started by talking about global cancer, and we need to understand that the future will show us a lot of increase in cancer in developing countries. So definitely over the next couple of decades at least, we'll see significant increase in cancer incidence and mortality in low and middle income countries, more than what we see in the US and developed countries. The reason here is that cancer is low or moderate in low and middle income countries now, but we see significant increase in life expectancy, and the population in developing countries are now more and more getting into older population, and cancer is a disease of older population. That's why we're going to see significant increase in cancer incidence. We're going to see significant increase in cancer mortality because the resources are not there in low and middle income countries for early detection, diagnosis, and treatment of cancer. This is an illustration of cancer in Uganda as an example. And as you see here, this is comparing the population pyramid of Uganda in 2000 with 2025 to 2050. As you see here in 2000, this is the wide-based population pyramid. And with 2025 and 2050, you see more of middle-aged population and more older population compared to younger population and compared to the population pyramid of 2000. So just considering the fact of aging of the population will translate into increasing cancer incidence and increasing cancer mortality. I'm showing this projection for Uganda, but this is the case for other low and middle income countries. So if you look at the statistics here for Uganda and you compare the breast cancer rates of 2000 to 2050, we expect 600% increase in breast cancer incidence if you compare breast cancer rates of 2000 with 2050, and 600% increase in breast cancer mortality. This is happening and will happen more in other developing countries, and we are not accounting here for changes in risk factors or other exposures or environmental factors. We are just doing this calculation based on aging of the population and how women, when they get older, this is an example of women for breast cancer, but this is for men and women, and aging of the population in developing countries will definitely lead to increasing rates of cancer incidence and mortality. That's why when we focus on global cancer, this is a very timely and will be a very important topic for the next 2 to 3 decades. So we focus our research in Africa and the Middle East, but we are open to the idea of training students in other parts of the world. So I'm going to talk about Africa today, but if you are interested in other parts of the world, let me know. We consider research in other parts of the world. So this is the cancer profile in Africa for males, mainly tobacco-related malignancies with lung and bladder cancer, and then varieties of cancer in sub-Saharan Africa with genetic susceptibility for prostate cancer, infection with liver cancer, and then HIV-related malignancies. For females, it's much simpler than male because it's breast cancer in North Africa and then cervical cancer or HIV-related malignancies in sub-Saharan Africa. So the main feature of cancer in developing countries is late-stage presentation, the red bars that you see here. So all around different countries, it's mainly late-stage presentation. This is an example of breast cancer, but it's the main feature for other cancers. In the United States, we see more early-stage breast cancer than late-stage presentation. But the main feature in the rest of the world is late-stage presentation of breast cancer and other cancers. So when we have late-stage presentation of cancer, this will translate into lower survival, high mortality, and lack of effectiveness of treatment. The second part of my presentation is related to the resources that we use for doing cancer research. Ideally, we would like to have population-based cancer registries. And as you see here from this map, we have about 30% of the US population covered by population-based cancer registries. And population-based cancer registry means you account for all cases of cancer in a defined population, and you have good population statistics, so you divide the number of cancer cases over the population at risk. If you don't have good accounting of the cancer cases, you have missed cases, you don't have good hospitals, you don't have good treatment facilities, you will not be able to do a population-based cancer registry. Also, if you don't have good population statistics, you don't have good census, you will not be able to account for the population and calculate accurate figures for population-based cancer registries. So ideally, to do good quality cancer research, epidemiologic research, you need population-based cancer registry. As you see here, Africa only has 1% of the African population covered by population-based cancer registry. But it doesn't mean that we don't have the good, high-quality population-based cancer registry, that we don't do cancer research. So we use cancer registries when they are available. So this is the Middle East Cancer Consortium, developed by our National Cancer Institute of the NIH, and we use the registries in the Middle East to work on cancer research and train students on population-based cancer registries. But in sub-Saharan Africa, they don't have cancer registries, and we work with cancer centers and cancer hospitals. To the left here, the white building is the Ocean Road Cancer Institute in Tanzania, where we trained over 25 students over the past years. And on the right is the Consortium Cancer Hospital in central Ghana, where we also trained about 10 students. So when we don't have population-based cancer registry, we utilize the existing hospital-based registries to conduct cancer research and also to train students. This was work of one of our students who went to Ghana in the central Ghana region, and she got the cancer cases from different departments of the Consortium Hospital. And she accounted for the population, created a cancer registry for the region, and published her paper based on the research that she started from scratch. Now I'm going to move to a couple of examples of large-scale studies that we do in Africa. This is the study that we have in collaboration with the National Cancer Institute on inflammatory breast cancer. And inflammatory breast cancer is a rare but very aggressive type of breast cancer. And the majority of breast cancer patients present with breast masses or lumps. Here, with inflammatory breast cancer, women don't present with masses or lumps. They present with red, erythematous breast, swollen or edematous, and the breast will have the picture of the podo-orange or podo-orange. It's like the peel of the orange where you have elevations and grooves here in the breast. It looks like the peel of the orange. The diagnosis of this cancer is primarily clinical. You cannot get biopsied like the rest of breast cancer cases and say, this is definitely IBC or inflammatory breast cancer. And the clinical picture is not necessarily presenting the same way in different populations. Even in the United States, the definition of inflammatory breast cancer varies from different women who get the diagnosis of the disease. We are interested in this disease because it's very aggressive and the survival of this disease is very low. But this disease, the inflammatory breast cancer or IBC, is rare compared to a very common condition, especially in developing countries called lactation mastitis, where women have inflammation of the breast and they have clinical pictures similar to the IBC clinical picture. This is cancer where patients must be treated with chemotherapy before surgery. This is the disease that can be treated by antibiotics for the most part, or you can make an incision and drain the pus here and the woman will be cured. This is very common condition. This is a rare condition. Here we don't worry about the survival. This is very aggressive type of disease. So we have a study in North Africa in 3 countries, in Morocco, Tunisia, and Egypt. And we are interested in this region because the proportion of IBC compared to all breast cancers is very high. So 10 to 15% of breast cancer cases in North Africa are IBC, but the same feature of low survival that we see in the United States, also the younger age in North Africa. We're interested in this study because we have large number of cases in North Africa. We have very interesting clinical presentations, and we have interesting epidemiologic factors also from our study in North Africa that are different from what we see in the US, where this cancer is significantly aggressive, but occurs at lower rate. About 1% of all breast cancers in the United States are IBC. So we recruited so far 220 triplets of this rare cancer. We have an IBC group, a non-IBC breast cancer, and a control group in the 3 countries. And we published 2 papers about the clinical presentation of the disease and also the risk factors. So we see that diabetes is a risk factor for this disease. And to collect 220 triplets from this rare cancer is amazing. This is the largest study in the world of this disease. We're continuing this study. There's an opportunity for students. We had many students in the past who engaged in utilizing the questionnaires, developing the questionnaires, using preliminary data, and this could be also an opportunity for training of students. We have also another study in sub-Saharan Africa in Tanzania, where we work on uncommon malignancies or non-AIDS defining cancers. So the 2 cancers that are known to relate with HIV are Kaposi sarcoma and cervical cancer. But now HIV patients live longer in Africa. They get the treatment. They don't have 100% intact immune response. and they are susceptible to other cancers, as you see here from the slide. So they develop anal cancer, squamous cell carcinoma of the eye, Hodgkin disease, thyroid. These cancers were very rare in Africa before the control of HIV. We had also students who published and utilized the study and analyzed risk factors from smoking and alcohol and food intake, and they found that HIV patients, when they live longer now, they have different lifestyles that are adding to the increase of these rare cancers that are increasing in sub-Saharan Africa, but they are also increasing in Tanzania. And these were two of the publications of students, Julie Campbell and also Claire Mernick on the uncommon malignancies in sub-Saharan Africa. We have students also who worked on HPV-related malignancies, anal cancer, vaginal cancer, vulvar cancer, and they showed significant increase in these HPV-related malignancies. This is very important for public health students also because HPV vaccination is being introduced now in sub-Saharan Africa, and these are preventable cancers. So it would be very interesting to look at the effect of HPV vaccination on the control of HPV-related malignancies in HIV populations. As Dr. Waterbourne mentioned in the beginning, we do global cancer, but we are also interested in domestic cancer. As you know, there are variations in cancer rates between different racial and ethnic groups in the United States for incidence and mortality. I'm not going to talk about domestic cancer today, but we teach students cancer epidemiology and cancer prevention in global settings, and they learn skills so they can come back to the United States and implement what they learned in domestic populations, or if they don't have jobs in global settings, they learn the skills and they can work on cancer in underserved populations in the United States. So from epidemiologic research, we take our findings and try to translate that to cancer prevention and control. As you know, because you are public health students, primary prevention is preventing the cancer from the beginning before people develop cancer, and that's modifying lifestyle factors, stopping smoking, good diet, increased physical activity. Or we can early detect cancer, and this would be second prevention, or diagnose and treat cancer, or deal with quality of life and improve life of cancer patients as they get the diagnosis. How can we think about prevention in different populations? It's population specific. What we do in Alabama or New York cannot be translated as is to Uganda or to Africa. So we need to work with different populations to understand the epidemiology of cancer in these populations and set the rules for who is at average risk, who is at moderate risk, who is at high risk, and who is at very high risk. And then based on the risk assessment, we can tailor the interventions, whether we're going to talk about primary prevention or we're going to talk about secondary prevention with screening and early detection, or we're going to deal with chemoprevention and other measures. If we say that we do breast cancer screening in the United States at age 50 and we start at mammography, maybe we need to think about different guidelines for women in low and middle income countries. Maybe we need to think more about other age categories based on breast cancer in this population, and also whether we need to recommend mammography or not in this population. And that's also another story that we need to talk about. Definitely in low resource settings, we should not be implementing population-based screening as we do in the United States. We should not be going to low-income countries and have population-based screening with mammography. Number one, the breast cancer incidence still is not high to justify mammography. Number two, they don't have the technicians, the mammography machines, the resources. And because the incidence is not high and they don't have the resources, we need to think more about low-tech interventions for downstaging, we can call it downstaging, or early detection of breast cancer. And we need to think about appropriate interventions for different populations based on what we understand from epidemiology and the translation of epidemiology to cancer prevention and control. So these are pictures of students in different countries. You see on the left here, a student immersed in medical records in one of the low-income countries. You feel with all these disorganized medical records that students will get nothing out of this, but students learn a lot from this experience and they publish. So our publication rate from this program is 70%. 70% of our students from this program, they publish at least one paper out of their summer research. And they publish because they go to places where they can get data and where they have the mentorship and they have the field site mentors who understand the nature of mentoring and mentoring students in these settings. We have varieties of countries and different stage of medical records. So we have students who work on computer files and students who have organized records, but we still have students who work in different countries on limited resource settings. We have varieties of countries where you have varieties of data for public health research and cancer epidemiology research. Some countries have national IDs where you can link and merge records. Some countries are still in the beginning of this stage. Internet connection, there are varieties of resources for research in different countries. I always love to visit with students, and Dr. Waterboard knows about this. I love to travel with the students to different countries, and I take the students to public health settings. Although this is cancer epidemiology program, but this is a huge opportunity for students to learn about public health in under-resourced settings. So we visit primary healthcare clinics. We meet with people who work under very limited resources to see how they do vaccination, childcare, maternal health, and different aspects of public health research and public health practice also, in addition to doing our cancer epidemiology research. We have a large network of collaborators from different parts of Africa. I think Dr. Waterboard met some of these people during our conferences in Michigan. And we bring our collaborators to see the presentations of the students and talk about different ideas for future students. The global cancer research, especially in low middle income countries, is interesting because there are challenges and opportunities. The challenges are the infrastructure, the representation of the data, the incomplete and inconsistent data, the limited traditions for doing research, but also it's a great opportunity for discovery, findings, publications, and learning also how to do cancer epidemiology research in underdeveloped and unusual settings. It's a great opportunity for training students because most schools of public health don't have the experience or the requirement of having students to go to limited resource settings to do especially cancer epidemiology research. And this program provides this opportunity. We also teach the students how to write manuscripts and how to publish from the data. And also, this is an opportunity also for talking about career planning and career development, and also how to deal with incomplete and inconsistent data. The idea of this program is to motivate students to pursue future career in global health, global cancer, and underserved populations. And we focus mainly on first-year MPH students from all fields and backgrounds and concentrations of public health. International students are eligible to apply and receive funding for this program, and PhD students can join this program at any stage of their career. So we have a process for application and how students develop the proposal, but this is mainly a summer program to go to the field and do the research and mentored research. We added a new post-summer career development workshop now in the program, and I'll show you some pictures about this. These are the countries where we have strong infrastructure for training students in domestic settings and in US settings, but we are open to different countries if you can show us that you have the infrastructure to do the research and that you're going to be hitting the ground up and running during the research, not spending the summer just seeing if you're going to be able to do the study or not. In the last 5 years, we started a post-summer career development workshop where we invite university professors and directors of NGOs, pharmaceutical companies, NIH representatives to come and talk to the students about jobs and career planning. And Dr. Stacy Fedwa is the director of the American Cancer Society program of epidemiology. She was a student in this program, the CEESP program, in 2006. So now she comes to advise the students after she got her MPH and PhD. We invited Dr. Emily Vogtman, who was Dr. John Waterbour's student, and she was our student in the MPH program, then went to in Alabama to got the PhD in epidemiology, and now she's at NCI. And we have different faculty who come and advise the students about career planning and career development after the summer and based on the presentation of the students. This was Dr. Jackie Levine, the director of training of NCI, who came and talked to the students about career planning at NCI and training opportunities of students at the NCI. So we provide this menu of opportunities to students because different students have different preferences after they get this global cancer experience and after they finish their public health program. So if you are accepted in this program, you'll get $7,200 for your 15-week work during the summer. We also bring the students twice to New York. I doubt that we're going to bring them in the beginning of the summer this year because we still have the pandemic, but we bring them usually twice to New York, once for orientation and another time in the end of the summer to give presentations about their summer work and meet with advisors for the career planning and the post-summer career development workshop. And we also pay for the students to go and present their work. It's a great opportunity for networking and introduction to different mentors. If you are interested in this program, please check the website. We have the videos of past students and they talk about their projects and what they did. And if you are interested, send me an email. We can set a time and talk about your interest and how we can work together and how we can make an opportunity for you through this program. I'll stop here and I would be happy to take any questions.
Great, Dr. Soliman. Thank you so much.
Thank you, sir.
I have some questions for you, but I'd rather hear from students who are tuned in or anyone else. I always have questions. I have about 6 of them, but you don't make time for me if there are other people that have questions.
Any questions? Maybe we'll start with you, Dr. Waterbour, and your questions will answer some questions that the students are shy to talk about.
Yeah, well, I can anticipate because I know about your program already, so I already had some questions. and we may not have much time. You can give me brief answers unless you think it's, worthwhile spending more time on. How or why are you in the countries that you're in? How did that come about that you're in certain countries in terms of sending students and not other countries? Is it personal contacts you've had or what?
It depends. It's an interesting question because Dr. Chamberlain and I are finishing a manuscript now that we're going to publish in the Journal of Cancer Education about how we develop the infrastructure. So as you know, we started this infrastructure 20 years ago. We add countries as we go. It depends on our connection and the collaborators in the different countries and how we can be comfortable sending students to be trained in some countries, but not others.
Great. Okay. Thank you. And you can't go, you're only one guy and you're very talented. You can't go around in the summer and spend major amounts of time with each student. Who are I would call them field supervisors? Are they physicians or do they have a PhD in epidemiology?
Yeah.
Who are they?
So we have different collaborators depending on the country as field site mentors, and they are usually MDs, local, or past students who worked in the country, or MD, PhD in epidemiology. I travel with the students. I go to different countries at least twice during the summer, and we alternate, Dr. Chamberlain and I. He travels sometimes by himself. I travel sometimes by myself, but we alternate between mentoring the students at least twice during the summer in global and also domestic settings.
Okay, great. Okay, got it. And anyone else break in because it doesn't have to be all me here. Is there a protocol? Let's say there are 6 different students in 6 different countries. Are they all they all have the same kind of activities in the same order? Like in the first 2 weeks, they're collecting data and the next 2 weeks, they're doing something else? Or is every student proceeding at maybe a different pace without regard to what the other students are doing in the program who are in different countries?
That's a great question. No, I think we don't have a set time schedule because it varies according to the different research projects. But we had more than one student several times in the same country, and they help each other because sometimes there is downtime for this project. The student here is waiting for a data set. The student can help other students in the field. So they work together, they learn together. Many times they are from different fields, not necessarily epidemiology, and they complement each other. And also, it depends on the pace and the project. I mentioned during my presentation that data and records, but not all the projects are data and records. Some projects would include interviewing. Some of the projects will include merging of data sets from the local countries. So it depends on the nature of the project and what's needed for the project. I would like also to say that speaking the local language is not necessary for these types of projects because physicians and researchers in many countries learn medicine and public health in English. So students don't have to speak the local language. We have softwares where we teach the students a few words just as greeting and survival words in different countries, but not necessarily being fluent in the local language.
Great. Okay. Another question for people who are in general, maybe very interested in your program, and I think there'll be a lot of them from UAB. Do they get to choose like whatever country they like within the number of countries that you mentioned, or do you try to match student backgrounds with particular needs in particular countries, or how is that done?
Excellent question. And I think you served on our advisory committee for several years. So we care about learning and education of the students. So we know that these students are not top-notch, well-established researchers, but these are research training programs where we want to teach them something. So it's tailoring the department or concentration of the department. So what we recommend for an epidemiology student is going to be different from a project for a behavioral science student, from health management and policy student. Also, because we know the field site mentors, we try to match the student with the site. So we can say that this student would do very well in Tanzania, but the same student would not do well in Ghana. That's why I need the students to communicate with me and talk with me to tailor the projects based on their concentration, personality, the local mentors in the country, and different factors that we consider in this. So usually students come with maybe 3-4 ideas. I talk with the students about the pluses and minuses of each project until we come up with the best project for the student.
Great. And you're to be complimented for taking all that time and trouble, not just taking any student and placing that student just anywhere.
No, this is tailoring projects to different students.
Yes. How much in that, again, anyone else break in that's got questions, how much do the field supervisors influence the projects that are done, or is it kind of up to you, or kind of up to the field supervisors like Dr. Soliman? I really need a student to do XYZ. Get me a student to do XYZ, or
excellent question. But before I say that, I want to say something that I meet with the students frequently to talk about the projects until we come up with the best project. And my range of meeting with the students to develop the final idea is 4 to 38. My 38 was Dr. Emily Vogtman. I met with her 38 times before she developed her project. So I always tell her that, and I say that because I have no problem in talking with the students until we develop the best idea that's satisfactory for the student and the student is excited about it. And I also feel that this is going to be a success story. So after we settle on the idea, we schedule Zoom calls with the field site mentors. So I have students now from different universities who talk with me, and the Tanzanian collaborators and the Egyptian collaborators and the Moroccan collaborators. So we talk with the field site mentors to discuss the details of the project, availability of the data, whether this is the good idea or we tweak the project a little bit or think about a different project, because we want to get the input of the field site mentors and the local people because they know their country and institution. So the students are introduced to the local field site mentors from now in the beginning of their discussion.
Great. Okay. Is there, can a student who has never been out of the United States, would they be welcome in your program, or is this kind of like
yes,
like a may not turn out too well, or what?
No prior experience. And we had students who had no prior experience and they were very successful, and having prior travel or global experience is not necessary in this program.
Okay. Another related question. If students, I know you're concerned with treating people with dignity and respect and so forth. Is there something that you or your associates meet with students in terms of what to say or what not to say, or what to do or what not to do, or how friendly to be to strangers, whatever the social norms are in that country that they're going to? How do they know that?
We do that during the orientation. So the 2 times that we paid for the students to come once before the summer is to bring past students who went to country X and come and talk about their experience in country X, and tell the students what to do, what to say, and how to navigate the system in that country. Sometimes we send prior students with the new students in the field to help them navigate the system in the foreign country. But definitely, this is a great point, and orientation and preparation is ideal. for having the best outcome.
Great. Just one or two more. Oh, I used your inflammatory breast cancer information, by the way, Dr. Soliman, when I'm teaching epi methods. I use that. There's kind of a math problem that goes with it. Just a scientific question. The inflammatory breast cancer, which again, you said high case fatality and kind of rare. Do we know or think that the cause of that kind of breast cancer is, in general, we don't know too well what causes breast cancer in the
We
US.
don't know.
Is it a totally different etiology? We don't know.
We don't know. We found that diabetes is a risk factor, but I think we are doing very interesting study now on artificial intelligence and how to diagnose the disease from imaging and mammography to be able to diagnose it, because the clinical picture is variable between populations and even within the same country.
Okay, last question for me. The COVID pandemic, which luckily we have a vaccine now that's coming. Who can anticipate where we're going to be at? That's not grammatically correct. In the summer, do you anticipate changes or big changes in your usual program due to the pandemic?
So the students who are communicating with me and the field site mentors in foreign countries now, we are planning for the worst case scenario. And the worst case scenario is that the students will not be able to travel and these projects will be done remotely. But if you ask me this question 3 weeks ago, I would say definitely this is remote learning. Now with the vaccination and changes and so on, I think I'm optimistic that the students will be able to travel, but we have our backup plan. If the students will not be able to travel, the projects will be done remotely and the students will be on Zoom with the field site mentors frequently to see how these projects will be done.
A sub question, that was my last question. In the countries, I guess it's a general question, which may have specific answers. The countries you mentioned, you had a slide, different countries, you've had placed students. How big a problem is the COVID-19 pandemic there? Or are there some of those countries, there's no cases at all? Or is it everywhere?
I think the students will be in safer places traveling to Africa than staying in the United States.
Yeah, that's
because the rates of COVID there are very low. I talk with the group, for example, in Tanzania, they had 0 cases now for the past 3 weeks.
And of course, we don't want students here who are infected to bring it somewhere else.
I think if the students will be able to travel, I think these countries will require some documentation or certification of vaccination or testing before the students transmit the infection to these countries.
Okay, again, thank you so much. I'll just tell people who are listening on the recording, John Waterboer, I'm a UAB faculty member. If you don't know me, I could be a local contact about this program. I'm happy to do that. The better way, or there's some questions I cannot answer, Dr. Soliman is very available on email, and I'm sure he'll be responsive. But if you have a question and maybe you already know me, I could answer general questions about it. And thank you, Amr, and I'll turn it back over to Katie.